Hi everyone, and welcome to the Origin webinar, What is Good Clinical Care for Young People with Borderline Personality Disorder. My name is Lee Crothers and I'm a clinical specialist at Origin, National Centre of Excellence in Youth Mental Health. Today we'll be hearing from Dr. Louise McCutcheon on the principles of good clinical care for young people with BPD. Louise is a clinical psychologist and co-founder of the Helping Young People Early, or for short, HYPE program 15 years ago. HYPE is an award-winning, integrated, team-based early intervention program for borderline personality disorder for young people in the western suburbs of Melbourne. Louise not only holds senior clinical duties as stream leader for HYPE, but is a senior program manager at Origin, National Centre of Excellence in Youth Mental Health. In this role, Louise tirelessly advocates for good clinical care for young people with BPD through service development and provision of consultation and training to mental health clinicians in Victoria. This webinar flows on from a previous Origin webinar titled The Rationale for Early Intervention for Borderline Personality Disorder by Professor Andrew Channon. If you missed this webinar, you will be able to access it on the Origin National Centre of Excellence website. This webinar will also be on our website at a later date. We'll keep you posted. To make this webinar more interactive, we will be asking you to answer some questions about your work with young people with BPD. These questions are also to see if we're providing the right information in a suitable way for you. It also helps us in planning for future webinars or training packages. You cannot be identified by your answers, but we will be able to show you in percentages what the group responses are at the end of the webinar. You can ask questions as we go along, and we will be responding to those we have time for at the end of the webinar. If we don't have enough time to answer all the questions, we will do so at a later date on our website. It's great you've joined us. It's really heartening to see how many people want to know about providing good clinical care to youth with BPD. It's my pleasure to hand you over to Dr. Louise McCutcheon.
Thanks, Lee. Welcome, everybody. First, I'd like to start with talking about the Australian National Guidelines for the clinical management of borderline personality disorder. And really, why I want to point that out is that they concluded that BPD is a legitimate problem, including in youth. It's deserving of care and resources. And they outlined a number of principles which we will briefly touch on today and refer back to. So they can be used as guiding principles for your management of young people with borderline personality disorder. So the second thing that they clearly said was that diagnosis needs to be appropriately and carefully made using the DSM criteria, that the treatment should primarily be psychological in nature, and that when you use medication for the treatment of borderline personality disorder, that really that shouldn't be the primary treatment, but it should be used in conjunction with psychological treatment. It should be part of routine clinical practice for young people with mental health services. Now I'd like to quickly go over the principles of early intervention for borderline personality disorder, just so that we're starting off from the same place. The aims of an early intervention program should generally be to prevent poor outcomes before they become entrenched and to promote healthier development. And so specific aims would be then improve functioning, to reduce psychiatric symptoms, and reduce or prevent harmful treatments, because we know those can occur, and to promote adaptive help seeking. So when we're thinking about how to set up an early intervention program, or what makes an early intervention program for borderline personality disorder, what we want to start with is the idea of broad inclusion criteria. And what we're thinking about there is that we want to view borderline personality disorder dimensionally, and we want to combine subsyndromal presentations as well as full threshold borderline personality disorder. And that's because we know that young people really with any borderline features in their adolescence are more likely to go on to have problems in their adulthood than young people without borderline features in their adolescence. We also want to limit exclusions for comorbidity or co-occurring problems, and that's because most people with borderline features actually have a number of things going on. It's not usually limited to their borderline personality disorder difficulties. They have many problems, and they're usually seeking help for those as well. We want to stress that early intervention programs need to think about diagnosis carefully and to find mechanisms to support their clinicians to do accurate diagnosis, and often that's through the use of semi-structured interviews like the SCID. Most early intervention programs are time limited, and certainly for borderline personality disorder, the programs that we know of so far are time limited, and they range for around 4 to 6 months in length, sometimes a little longer, but usually they focus on 16 to 24 sessions of treatment. And the treatments that they offer, or the interventions they offer, are need to be developmentally targeted and appropriate. So it's not enough to just take an adult program or a treatment developed for adults and to use it with younger people, that we need to modify it. In our program, we use cognitive analytic therapy, and we've modified that for the use with young people. So now I'm going to go back to Lee, and she's going to ask you some questions, and then we'll carry on. Thanks, Lee.
So the first question, do you work with young people with borderline personality disorder features? Select one of the following: yes, no, or I'm not sure, I would always recognise it. The other one, do you work with young people with borderline personality disorder features? Select one of the following: yes, no. Sorry, I think we're experiencing some technical problems. Apologies, everyone. Are you still with me? So the next question is, how confident do you feel working with a young person with BPD features? And select one of the following: I do not feel confident at all, I feel somewhat confident, I feel moderately confident, or I feel confident. Thanks for selecting those. I can see the responses. The next one is, do you use a particular framework to guide your work with BPD in young people? No, I use my general clinical skills, or yes, I have some training in a specialised BPD treatment. Thanks, everyone. And the other one is, what do you think is the biggest barrier to the provision of treatment for BPD in young people? I do not have any training in a specialised BPD treatment, or diagnosis and treatment is not encouraged in our service, or our service can't cope with the risk and complexity. Thank you. Okay, we'll go back to Louise. Over to you.
Thanks, Lee. Okay, so when most people start to think about what appropriate treatments might be for young people with borderline personality disorder, they tend to think of the specialised psychotherapies. So what comes to mind are DBT, dialectical behaviour therapy, or mentalisation-based therapy, Sometimes people think of schema-focused therapy, even transference-focused therapy. There's cognitive behaviour therapy, and of course cognitive analytic therapy. So the list goes on. That's actually not even the end of the list. There are more. The difficulty with thinking about the use of those specialised treatments is that, generally speaking, the outcomes are modest at best, and those treatments don't really address functional outcomes, so that even though people might start to resolve in terms of their symptoms of BPD, generally speaking, they're not living healthier, more functional lives at the end of that because we haven't addressed those needs. And the biggest problem really is that those treatments are often quite intensive and long-term, and the majority of people with borderline personality disorder don't get access to those sorts of treatments. So when we know now that there are a number of evidence-based treatments that have been tried out with young people and tested using randomised controlled trials. We now have had 5 randomised controlled trials of treatment in young people, and all of those treatments, except for the 5th one, which was a medication study, and I won't talk about that today, but the 4 treatments that have been used with young people have all been modified for use with young people. So we've looked at cognitive analytic therapy in our service. There's a Dutch service that have looked at emotion regulation training, and then mentalisation-based treatment has been tested and evaluated in the UK, and DBT has been looked at in Norway, I think it is. When we look at the outcomes of all of those studies, what we found is that they found outcomes, improved outcomes for young people across all of those treatments. But there was a wide variation in the comparison treatments in those studies. So some of them looked at treatment as usual, which was not manualised. Others looked at the enhanced usual care, which again was not manualised. And the comparison treatments often had no treatment integrity measures, which really means that we don't know what they did, and we don't know whether they did what they said they did. So we don't know how consistent those treatment alternatives were. So we don't know what the specialised treatments were really compared to. There's only been one randomised controlled trial that's actually had a manualised control treatment, and that was the one we did. And we called our manualised treatment good clinical care, because what we wanted to do was set up a treatment that was a good comparison treatment rather than just treatment as usual. Now, what we know from all of the studies is that interventions, even the treatment as usual and the enhanced usual care, were able to demonstrate that treatment is useful for young people with borderline features. But what we could also say, looking back at those studies, is that the structured interventions appear to outperform the non-manualised treatments. So if we now look at what an early intervention program for borderline personality disorder should look like, the key elements are that there's a consistent, common, plain language model across all aspects of care, that there's an explicitly collaborative approach with patients, so much more of a doing with or rather than a doing to kind of approach, that we need to involve young people in the treatment as much as we possibly can. We also want to have some way of measuring what people are really doing in their treatments. So we want to have good systems set up for individual and group supervision of staff, and we want to be able to check back against the model that we have. So we need to have a clear model in mind about what the program's trying to do. This is a bit of an example about a psychological informed model, and what we're trying to demonstrate here is that the way you set up the service that provides the case management, the psychiatric management, the family interactions, and how we engage with acute services and engage within the team needs to be clearly informed and clearly articulated. And it's also that part of the model that is perhaps even more important than the actual brand of the individual therapy that you use. So not everybody coming into your early intervention service is going to access your individual psychotherapy. We try and deliver it to everybody who comes into our program, but actually not that many people complete the whole contract of psychotherapy, and that would be a common experience with most borderline personality disorder services and most early intervention services for borderline personality disorder. So we need to make sure that the model that we're using is consistent and is psychologically informed so that we can understand what it is that we're delivering. This is another way of displaying the key components of an early intervention program. So you can see the integrated outpatient care involves assertive, psychologically informed case management, and that's integrated with your early intervention. Now, sorry, your individual psychotherapy. I'll talk a little bit more about each of these components in a moment. It needs to be integrated with your general psychiatric care. So there's treatment available for the co-occurring problems and for physical health, as well as crisis and acute care, and that they work together. The family interventions that you offer need to also be integrated with your whole program. So the way that you approach family work and work with families and friends and carers and even other systems that the young person's involved with all come from the same sort of model. And then, of course, there are final other components that include things like supervision and treatment integrity. So we'll go through those in a moment. To start off with integrated outpatient treatment, we've used the word assertive quite specifically because young people with borderline personality disorder really can't be expected to have the life skills that we expect of healthy adults. So we know that they often don't have any idea what treatment might involve, what psychotherapy involves. We can't assume that they know what they're refusing when they are struggling to engage with us or struggling to attend our services. So we often think about the idea of informed refusal, that we really need to give people a sense of the service, a taste of the service, if you like, before we can take a no, before we can say, yes, they know what they're refusing. Now, of course, we're not going to persist if people are really very clear they don't want to engage with us. But it does mean that we need to be a little bit more assertive and active in our involvement, early on particularly in our involvement with these young people. So we tend to think about responsibility for attendance and engagement being a little bit more weighted towards us doing the work early on, and then increasingly handing that over to the young person as we go on. So because of that, we need a capacity for outreach. We need to be able to offer at least some appointments early on in the community or where the young person is, because not every young person is going to be able to come into our service. The psychologically informed part of the case management is really a way of describing that the model needs to be reflective and thoughtful. We need to really clearly think about the goals that we're working towards with young people. And that includes goals for the treatment of the co-occurring problems. It includes goals for psychosocial recovery. We need to have educational and vocational goals high on the priority list because this group of young people often do very poorly in that regard. And our treatments are generally not well focused on those goals. So we need to think about our case management being focused on those goals. We've talked already or mentioned already that most of the early intervention programs are time limited. Now that could be that we have review points. It could be that we have a strict limit about how long people can engage with us. It's less important, that part of it. It's more important that we actually stop and think regularly what it is we're working towards. And we give people opportunities to try things out without us. What we don't want to do is promote dependence. We want to promote autonomy and young people moving in and out of care when they need it most, not thinking of themselves as chronic patients who will need case management for the rest of their lives. We also want to think about balancing engagement and limits and really working with expectations rather than rules. So what we do commonly is talk with young people when they first come into our service about how the treatment might work, about what we're expecting of them, so that they have a sense of it as opposed to reading out a list of rules. The general psychiatric care is really referring to how the doctor's role might look in a program like this. So primarily the doctor's role is going to be for medical management and review of risk. They're going to be thinking about pharmacotherapy and what decisions they make, and they're going to be thinking about the physical health of young people. And what we want to stress is that the general psychiatric care really needs to be well integrated with the case management and the individual therapy that's being offered. So they need to work together as a team, and that's important for sharing risk management and decision making, for sharing the formulation and the understanding that you have of why the young person's presenting now and how their problems have emerged, for sharing the way that you work together and your approach and the messages particularly that you're giving the young person. So ideally having shared appointments as much as you can. We've already mentioned pharmacotherapy very briefly, and I want to stress again that in early intervention it's important that we consider that pharmacotherapy is really for the treatment of the co-occurring problems, so major depression or other sorts of mood disorders, for the treatment of other issues. It might be sleep, for example. Sometimes it's appropriate to use medications for short trials of treatment for for sleep management. But generally speaking, what we're thinking about is not using medication for the primary treatment of borderline personality disorder. One of the things to look out for particularly is polypharmacy. We know that in surveys when people have looked at the number of medications that people with borderline personality disorder are being treated with, that it tends to be very few or a lot. And so we want to be quite reflective and thoughtful about how we use medication and also how we talk with young people about medication. Acute care is also important. We need to think how to have our crisis responses be very goal-directed and supportive and available, but clearly working towards the young person using those systems and services appropriately. So we want to encourage increasing responsibility for the young person to ask clearly what they want from us and for us to be responsive when they do, rather than encouraging them to become more and more demonstrative in terms of their self-harm or their demands for support. The more we reject people and the more we turn people away, the more likely they are to up the ante and engage in really risky behaviours. So we want to have a collaborative discussion about how young people use acute care services, and we want to set up our crisis teams and our inpatient care so that young people can use them effectively. Inpatient care, we particularly want to have that be focused on brief stays, so 24 to 48-hour admissions, and being primarily for the containment of risk rather than anything else. It is possible, of course, that young people might need to stay longer at different times, but if we can focus on our usual management being brief, then that helps contain things. And it helps young people learn how to use inpatient and acute services effectively. And then we come to individual therapy, which is usually in our services delivered by the same person who does the case management. It doesn't have to be, but by combining that person and having that person do two roles, case management and individual therapy, it allows a much better integration of those things. The more people that you have involved in a treatment team, the more possibility there is for differences of opinion and for misunderstandings or mixed messages to be given to a young person. So we integrate those two roles together. I've just briefly mentioned already that our program uses cognitive analytic therapy for the treatment of borderline personality disorder, and we have modified that for use in young people. We offer 16 weekly sessions. It is a slightly flexible contract in terms of being able to extend if a young person is using it effectively, and we think that's helpful. But most of the time, young people are offered 16 sessions, and that's the maximum. The focus in the treatment that we use is on a shared formulation and on agreed ending, and that's very important. That doesn't mean we discharge everybody immediately at the end of that. Sometimes young people need a little bit more care and case management, but we're expecting that most people will be settled enough to be discharged at that time and to have some follow-up when we might review how they're going and whether they need more care. So the summary of all of those components of an early intervention program are that you offer assertive case management, and that's integrated with the psychotherapy. There's a capacity for outreach. There's a focus on psychosocial and vocational recovery, that it's a time-limited treatment, and so we offer intermittent or episodic care so people can dip in and out when they need it. We also try and always have some family or carer involvement. That's not always possible, but I'll come back to that later as well. And we try and think about informed refusal as well as informed consent. All of that is integrated with psychiatric management, and we try and have brief, goal-focused inpatient care, and we try and make sure that we have supervision and treatment fidelity measures. So now we're going to move on to what does good clinical care actually look like. So what I thought I would do is come back to the general sorts of principles of the good clinical care. So we're leaving the individual therapy to the side at the moment, and we're thinking what should the overall case management be working towards. Now it may be that you do some of these things as part of your individual psychotherapy, that's fine. What we're trying to do is describe a good enough model for early intervention for borderline personality disorder. So the first point is to attend to the diagnosis and to psychoeducation. The second thing would be to think about the working relationship and how we can set that up. Then we're going to talk a bit about structure and how to balance flexibility and limits. Think about collaborative management plans. Think about crisis planning. Think about how we work on endings and transfers, and then come back to the idea that we need to involve family members, carers, and other people in our treatment of young people. So we're going to go through each of those one by one. So the first place to start is to make sure that we actually have young people with borderline features in our program. And to do that, we really need to have some way of screening or making a diagnosis effectively. When we do that, we want to also make sure that we provide psychoeducation. Now, I think I've just managed to have a repeat slide, so I'm going to move on. Firstly, we want to have some screening to identify who are the people that we want to assess, and then we're going to think about the sorts of tools that we might use to back up our diagnosis. You don't have to use a semi-structured interview like the SCID, but it's quite a good guide, and it helps the people who are the clinicians who are doing the diagnosis be consistent in the way that they make that diagnosis. The main important point, I think, is to use the same criteria, and at the moment our services in Australia use the DSM, so I would be recommending, or we would be recommending, that you use the DSM features. The important bits about psychoeducation, I think, are that we want our psychoeducation to be targeted, which means talking about BPD in young people, not just BPD generally. And we want it to be tailored, which means that you need to refer to the specific problems that a young person is presenting with. There's no point in telling them about all the other features that they don't have. We need to really think about how to make the psychoeducation that we do and the psychoeducational materials that we use specific and relevant. We also need to remember that this is a dynamic conversation, so it does change over time. We want to be able to come back to it and to refer back to it and to understand how the young person might be thinking about the idea of a diagnosis, how they think about borderline personality disorder, how they're making sense of it in their own way, and be able to deepen their understanding of those ideas over time. The second thing we mentioned was the idea of setting up a working relationship. How do we do that? So it's important, I think, when we're working with young people with borderline personality disorder to remember that they often have experiences of great difficulty in their lives, and they often have experiences of adults not really believing their story or thinking that they're exaggerating or generally invalidating their stories. So what we want to do when we're setting up a working relationship is see how we can encourage trust and understanding and a feeling that we get what they're saying or we understand how things are from their point of view. That doesn't mean we have to agree with everything they've said or even believe everything that we've said or that they've said, but we do want to give them a reassurance that we understand that their life has been tough so far. Another thing that can be really important is to think about the fact that they're doing the best they can. If we are taking their behaviour or the way that they're interacting as something personal that's directed at us or as a manipulation of us, that can be very difficult to set up a working relationship. It's much easier if we can see those sorts of behaviours as being the best that they can do in the circumstances. So taking that point of view usually makes the working relationship easier. Understanding that most of their problems were at some point an attempt to find a solution out of a problem is also another helpful way of thinking about it. An example would be self-harm. Self-harm is actually a very effective way of managing feelings of distress. So if we can see that particular problem as being once a solution, perhaps now not working so well, that helps us address those issues a little easier. In thinking about how we can set up the working relationship, we can also understand that many young people, when they're coming for help for these sorts of issues, are particularly stressed. It is a stressful time when you're in crisis and when things are not working for you. So we can often quite simply help people manage stress and distress fairly easily and fairly simply. We all have good skills for helping stress, and those sorts of issues can be applied fairly quickly and easily to young people with borderline personality disorder. Now, we might do that individually, we might do that in groups, and sometimes just even referring young people to where they can find that information to build up more strategies for managing stress can be a helpful intervention in itself. Going back to the idea of setting up the structure, I mentioned earlier that what we do is try and talk about expectations rather than rules, and I think this is an important thing to think through carefully. If we start with the service seeming to be a very rigid structure, then often what we get is a lot of challenging of that. If we can set the scene for collaboration together with the young person, that we're interested in how they like to be seen and how they think things will work with them, then that usually makes for a more collaborative relationship. There are, of course, some boundaries and some limits that we do need to be clear about. It's important, for example, that if a young person is talking about carrying weapons, that we would need to address that. Or if a young person is talking about serious, heavy substance use, that we would probably need to address that as well. It's going to be difficult to do treatment with somebody if they're substance affected most of the time when we see them. So we could have a conversation, though, about how we can work together around that issue. Can we change the times when we see them? Can we come and visit them or see them in a safe place that's closer to where they live? All of those things might be ways of negotiating a more effective relationship without us having to give in and them having to fit into our rules. So I think the final point on this slide is important, because some of the issues that we want to talk about in relation to limits are really about our needs rather than the young person's needs, and we don't want to dress up some of the things that we're talking about as being for them when really it's our need. So an example of that is about carrying weapons. We can't have somebody on site with a weapon in their bag. That's our need, to have the whole service be safe and the staff and the other young people in the service. It might not be something that the young person sees as their need. So we need to be clear about what are our needs and what are theirs. Motivation is also an interesting thing that's worth thinking about in relation to the setting up of the relationship. Young people who have personality difficulties often want a better life, but may be feeling quite ambivalent about how to change things. Now, sometimes that's because really young people have no idea how things could improve. When we talk to young people, for example, about how they could have a better relationship with their family, they're mystified and they have no idea that things could be different. So sometimes we need to do a bit of work around how we could help young people imagine something could improve. We also need to think about how to be open and transparent with what our expectations are. So we don't want to be overly optimistic about how things could improve. We want to be as realistic as we can. And we need to be clear about what we think would be helpful goals to work towards. We also want to have the process of designing management plans be as collaborative as we can. So if we're focused a lot on a collaborative relationship, we need to get the young person's input. We need to know what sorts of goals they want to work towards. And I think having a balance of both short-term goals as well as long-term goals is important. We've already mentioned that there should be a mix of educational or vocational goals, and really very functional goals should be in that management plan. We also want to think about how we might help a young person think about practicing the things that they're learning in the treatment that you're doing. So we want to have, as part of the plan, a way of checking in or practicing or reviewing those goals. And we want to generally stay away from arguments. One of the things that is very clear is that if you get into an argument with a young person, probably they will win and we won't win. So it's better to stay away from those and to find language that we can both agree on. An important thing to remember about management plans is that we want to be as consistent as we can, and that brings us back to that idea of integrating the case management, the therapy and the general psychiatric care. That if we share the management plans and the crisis plans with the young person and with the people in their environment, as well as within our own teams and our own services and the services that the young person is engaged with, we're much more likely to have a consistent management plan and to be able to work effectively towards that management plan. So we need to set up care team meetings or case conferences or whatever it is that you call those meetings, so that we can facilitate better communication and consistency across the people that are involved with a young person. And we want to establish as much as we can a common language for interacting with that young person. And that might actually involve giving workers specific sentences or phrases to use that we've started to develop in the treatment together with the young persons so that we're all on the same page. We want to also make sure that those management plans include the treatment of co-occurring problems. We know that young people often present with really complex difficulties, especially when they're coming to tertiary mental health services. But even when they're presenting earlier on at their student welfare coordinator or their GP practice in primary care, often they've already experienced a number of co-occurring problems. So we need to make sure we don't lose sight of those things. We want reduction of risk, for example, to be somewhere in that management plan, even if it's not specifically referred to as such. Just thinking about crisis management, often young people with borderline personality disorder have frequent or intermittent crises. We want to generally improve young people's problem-solving abilities, and that can be a fairly simple sort of task. We want to help them think through the problems and be able to solve them as much as possible in their own networks and by themselves, and then be able to come and seek care from people when they need more help. So we want the management plans and the crisis plans to be clear and collaboratively negotiated. We want to do them with the young person. So we need to be able to identify the points at which a young person does something differently, the people around them do something differently, and particularly when we need to intervene. We also want to have as consistent as possible response to risk, and particularly risk of self-harm and suicide, but also risk to others and the other risks that might be associated with young people's presenting problems. And that means finding alternative ways of managing distress or negative emotion or interpersonal difficulties. And it also means educating the people around the young person for how they might respond in a helpful way when someone's in crisis. We also know that containment is important when young people are in crisis, but it's not always best achieved by going to hospital. Now, that's a tricky thing because often services use hospital as the first point of call for containing situations that they can't contain in their appointment. So it can be difficult for clinicians who are starting out in this work to develop other ways of thinking about containment. But it is important to think through, have we thought of everything else? Have we thought of ways that the young person might feel more contained in the community? And that might be by increasing outpatient appointments or getting more support from the wider relative group outside in the families, or it might be in friends and other networks. It might be other supports from other agencies. It also can be that we need to increase the consistency and predictability of people's responses. That in itself can be containing. And for ourselves, we need to think about how to use colleagues, peers, supervision, and the treating team that we are part of. So making sure that we don't carry all of the responsibility for thinking through the management of crises on our own, but that we ask for assistance and consult with our colleagues frequently, particularly in situations that are risky. And it's not from a point of view that we're not competent ourselves, but more from the point of view that we're sharing the risk, that it's important that other people know when our clients are engaged in risky sorts of behaviour or we're concerned about the risk, and that we're thinking of as many things as we can, and that we're looking out for our own blind spots. We can't possibly think of everything, and using and consulting with other staff helps us to think through those options and to make sure we haven't missed anything out. Another area that's really important is to be thinking about how to manage endings and transitions. So we know that young people with borderline personality disorder are often sensitive to breaks in care, to endings or transfers, to temporary gaps like your case manager going away on holiday. And we know that addressing that openly with young people can be the first step in trying to help them manage those things better. So open discussion from the start, setting things up so that people aren't surprised, and have plenty of time to work through the issues. One of the benefits of having time-limited treatment is that you get the ending on the agenda, so to speak, right from the beginning, that it's something that you can come back to when you need to through the treatment, so that the young person has had plenty of time to process it and make sense of it and to manage it as best they can. There are also a number of techniques that you might want to use that help mark the ending and help young people process the ending. So there are all sorts of rituals like writing letters or celebrating endings, and that provide an optimistic and confident kind of message that we think young people can manage when we finish with them. We also want to stress that in general, where we can, we want to discharge people to non-mental health services so that they get the message that they don't have to be a patient for a long period of time, but also help them understand how to refer back to us when they need to. And finally, we want to make sure that we've thought a fair bit about how to involve families and carers and other people in the young person's system. So we know that many families of young people with borderline personality disorder have their own difficulties. BPD is a complex problem, and some of that has to do with the genetic origins and the environment that they've grown up in. What we want to be very clear about is, though, that families are doing their best and that it's not their fault that their young person has developed borderline personality disorder. But they can be involved in improving things and to improve communication and supports, and they can also assist the young person to negotiate the developmental sort of stages that they might be going through, so increasing autonomy, for example. And we want to involve families as much as possible to give them support, because it's a tough deal, having someone live with you who has borderline personality disorder, but it's also tough for the young person, and we want to facilitate as best we can improvement for everybody concerned. Another issue that we're going to speak about very briefly before we finish up is that we need to assume that tensions will occur as part of the work that we do when we're working with borderline personality disorder. Often we're talking about situations of intense kind of emotional content. We're talking about working with young people whose interpersonal skills are challenging, and many of the stories that we hear from young people are distressing and upsetting. So we need to assume that there will be differences of opinion occurring between clinicians. Many of us have different theoretical backgrounds or come from different disciplines, and so it's not surprising that young people will provoke us to have different ideas about how we should respond and what might be the best way forward. And risk particularly is likely to exacerbate those differences of opinion. So we want to make sure that teams can find a way to come back to the idea that we're all doing our best, we're all trying really hard, we have the young person's interests at heart, and we need to be reflective and collaborative and open with our colleagues as well as with the young people that we see. And the best way to do that is to have an overall model about borderline personality disorder and early intervention that will help contain us. So my final thoughts are that if we can, we need to maintain a reflective overview of the progress of the young person. We need to keep a reflective view about what we're trying to do. It's easy to be caught in crises. We want to set achievable goals and also have time to celebrate the successes that we have, even when they're small. We want to make sure that we set things up so that we have consultation and supervision available for everybody working with this population. We want people to use supervision and senior colleagues and peers, not only to manage the tensions and the challenges, but also to stay on top of what we might feel pulled or pushed into doing. It's very easy to get off track, and we want to be able to understand when we've got off track and to get back on track, to notice what our particular blind spots are, and to be able to find ways to manage the intense days that we might have at work. So supervision and consultation are particularly important. Now we're going to go to the final interactive questions. Lee, I'll hand back to you, and then we'll be finishing up. Thanks for your time.
Thanks, Louise. This is our last question for the audience. Before we go to a poll summary, we'll show you what the audience has told us. And then you can have some time with Louise around some questions. So the question is, how confident do you feel now about working with a young person with BPD features? So I do not feel confident at all. I feel somewhat confident. I feel moderately confident, or I feel confident. So thank you very much for responding to the questions. So we're going to summarise some of the poll questions. And this is interesting. We've got the right audience here, which is it's good to see. We've got 81% of you work with young people with BPD features. And it is interesting that 11% are not sure, probably because perhaps people don't diagnose, or maybe they're discouraged from diagnosing. That would be interesting to hear as well. And most people feel somewhat confident in working with a young person with BPD features. So that's good to hear too. Not many people felt I do not feel confident at all, and not many people feel really confident. This is interesting too. Do you use a particular framework to guide your work with BPD and young people? And most people use their general clinical skills, which is good to hear when we're thinking about good clinical care. We haven't got the correlation, but that would be interesting to see if people feel confident too in using their general clinical skills. And the last one was about the biggest barrier to the provision of treatment for BPD in young people. And most people selected saying that they don't have a training, they have the training in specialised BPD treatment. And I wonder if people think that's a barrier now after hearing about the good clinical care principles. And back to how confident you feel now about working with a young person with BPD features. And we've got a bit of an up, I suppose, a bit of an increase in I feel confident. It's double, I think. And a bit of an increase in I feel moderately confident. But that's nice to see. Only a small percentage of you don't feel confident at all. That's great. Thank you very much for your responses. They're interesting responses. We're going to go to some time with Louise around some questions. People have put in some questions, but you might want to think about if you've got any more. And if we don't answer them all, we will put them up on the website alongside this webinar and the PowerPoints people have asked. Okay, I'm back with you. Louise, we're going to go to you in a minute about responding to some questions from the audience. There's been some really interesting ones. The first one is, What skills are offered in the HYPE program to help young people manage their symptoms?
Thanks, Lee. Oh, that's a complicated question. Generally speaking, we draw from a whole range of frameworks. Our overarching framework is cognitive analytic therapy, but that doesn't give us the actual skills that we use. The skills that we use would come from cognitive, behavioural, narrative, DBT, MBT, anything you can think of that we've heard of, ACT. So we pull skills from a whole range of different places. I think you can easily find handbooks on stress reduction that provide you with lots of different ideas. What we want to encourage people to think about is that it's not so much a particular technique, it's about having an overarching understanding of what's going on and then working with a young person to work out what skills they need to learn. And then I think you can easily access handbooks and things like that that will help you think about the skills that someone might want to learn about stress reduction or whatever it might be. Okay?
Thanks. I suppose most clinicians in the HYPE program do have different skills, but the good clinical care model is the overarching model.
Yeah.
The other question that we've had is whether you believe good clinical care is better than a specialist treatment.
Well, that's a very good question. I think good clinical care is a really good place to start. And the reality is that most young people will not access a specialised borderline personality disorder treatment. Even if they come to HYPE, the majority of people get mostly good clinical care and then some cognitive analytic therapy. So even though we try and offer both to everybody, they don't always engage in it for long enough or in a way that we can deliver that to them. Sometimes they dip in and out of our program very, very quickly. And so I think what we need to be mindful of is that many young people don't need as much treatment as we think or don't want it right now anyway. And we need to be able to offer them brief treatments and simple treatments, and those that want and need more, we hope will come back and engage in the more specialised treatments. So I think we all need to be able to feel comfortable to provide good clinical care because that's what more people are going to actually access from us.
Thanks. You did touch on this. This question came in early, so you might want to expand on what you've already said, Louise, but it asks how best can families be involved in the treatment of young people with BPD?
I think it's important that we know that in the age group that we work with, which is 15 to 25, a large majority of people have disengaged with their families. So it's more than half have disengaged from their families by the time they turn 18. Now, that doesn't mean they don't have connections of some description with their families, but they're not living with their families anymore. So it is harder, I think, to engage families when people have started to disengage from them. However, I think it's really important to try and aim for that. So when young people are living with their families, we try quite hard to involve them. I know that young people sometimes don't want us to do that, so we would not force the issue, but keep in the back of our mind that we want families involved. And the minimum that we would try and aim for would be to have them involved in the assessment process, the kind of discussions about treatment planning, to be involved in medical reviews if possible, and to be involved at the end as well, and at various points that they might want to be involved. For example, if there's a crisis or something like that, that might be an appropriate time. Now, some young people are really happy to have their families involved, and they might be very involved all the way through, and that's fine. It's rare for it to be a problem that families are involved. Mostly our experience is that it's helpful to have families involved, and so we work quite hard to try and encourage that.
Thanks. The last question is, how can we move our service towards a good clinical care model for young people with BPD? What do you think the first steps are, I suppose?
I think that's actually a really, really good idea, question. One of the important things is actually that the service, and that includes everybody in the service, and particularly the more senior people in the service, need to be on board with the idea. So it might mean that you need to start off with more professional development, more discussion about some of the recent literature, or encouraging people to consult with people who know about early intervention for borderline personality disorder. We come and do workshops, for example, in services when we're asked to, or to meet with service leaders. So it doesn't have to be us, but it could be people that know a bit more about early intervention for borderline personality disorder. Because if your service leaders don't see that as a priority, then it won't happen. Now, if you're still having trouble getting the idea off the ground and you as clinicians want to do something about it, then I think there are individual things you can do. You can offer individual good clinical care. But what we know from the literature so far is that the structured programs seem to be able to offer something more over and above treatment as usual. So I think it's important to have a coordinated early intervention program if you can.
Thanks, Louise. We're going to close the webinar soon, so before I do, I want to thank you for tuning in and participating in the polls, as well as putting forward some thought-provoking questions. Thanks, Louise, too, for your time. We hope to see you at future Origin webinars, and to access these, please keep in the loop by checking our website and signing up for our mailing list if you haven't already done so. Thanks, everyone, again. Have a good day.